Yep, hi. Been called to a patient that's 72 years old. He had chest pain. From my notes on my screen, his pain has been relieved because as the patient's taken his own GTN, but that was subsequent after we had already been called to the scene. So we arrived at scene. Obviously, as we came in, we first were looking at scene safe, putting on our gloves, and calling out. The patient didn't come to the door, but was in bed and did call to us to say he's in his room. So we've come in, and as we're going into the room, we're introducing ourselves. So my name is Richard Betts, St. John Ambulance. What is your name?
My name's Pete.
Hi, Pete. Can you tell me your date of birth, Pete?
24th of the 12th, 1945.
Okay, Pete. So, Pete, as I'm talking with Pete, I'm also just visually looking at the room, seeing that on a side table there's a bottle of GTN, but no other medications, and just a glass of water. I'm seeing that the room is kept well. It's not no distinct smells, and everything's looking in order. So I'm just going to go talk to Pete again. Pete, you've called us tonight because you had some chest pain. Are you having chest pain right now?
No.
Okay, that's great. I'm really happy to hear that. So Pete, what we want to do is we're going to want to just assess and find out what's been going on. If it is essential for us to go and take you on to hospital. And in doing that, I will need to obviously examine your body, touch your body. Are you happy with that?
Yep.
Okay, great. So I'm looking at Pete. He's talking full sentences to me. He's not looking pale, clammy. He's not looking gray. He doesn't look short of breath, which is good signs. So first of all, as I'm going in my mind, what I'm looking at is just the ABCs: his airway, his breathing, and his circulation. And I've covered that in those couple seconds. Next, what I'm going to be doing is I'm trying to do a differential diagnosis. So I'm looking at, yes, he's called us for chest pain, but it could have been a number of different things. It could have been pneumonia, pulmonary edema, pericarditis, a pleuritic pain, pneumothorax, AAA. It could just be even something gastric or something that's deferred pain from somewhere else. So I'm trying to do is I'm going in with a broad spectrum and then trying to narrow down and make a diagnosis, and to figure out what would be the best plan then for Pete. So I'm going to be using questions, and mnemonics that we use is PQRST, actually OPQRST, which is the onset. When did the pain come on? How did it come on? What provoked the pain? What was he doing? Was it at rest? Was it in movement? What's the quality of the pain? Was it a sharp pain? Was it radiating anywhere up to his neck or down his arm? And just even the region, if it was more central or whereabouts it was. And just even the severity of the pain, giving a numeric value of the pain from 1 to 10, trying to find out what was this pain like when it came on for Pete. Also the time that it came on, and what was he doing at that time as well. Also in my questioning, I'm going to be using, in this differential diagnosis, using another mnemonic is sample, which is looking at just the signs and symptoms that Pete's having, and then that will come out even as we're examining. Asking even if Pete has any allergies, medicines, foods, finding out even if that's possible reasons for the problems that he's having. Medications, what medications he takes, because this is going to help even in finding out if there's been changes, because that potentially could have caused some of the problems that we're having. Past medical history, again, it's giving us a history of what problems Pete's had in the past, and that could even help us for making a diagnosis. Last, oral intake. And as I've said before, even the events prior leading up to this event. I would ask Pete questions even like, have you been normal bowels? Has he been constipated? That could create abdo pain and even deferred pain. If there is family around or friends that are there, just asking of them also if this is Pete's normal presentation, or if it could be that Pete's got some dementia and can't really answer the questions normally. So it's to get information not just from my patient but also from those that are around. So then I'm going to basically going back to Pete and just assessing him. I'm going to be almost initially going to be going in there and just asking Pete, it's okay if I just take your pulse? And as I take that pulse, what it's telling me is that obviously he's got a pulse, which means he has a systolic blood pressure of more than 80. It's telling me if it's thready, if it's bounding, if it's what kind of, even initially what kind of cardiac output it's doing. It's giving me a rate. It's telling me if it's regular or irregular. So these are very important things. And as I'm there, I'm also just looking at his hands. I'm looking at the color of his hands to see what's the kind of perfusion he's getting down there. Are they cold? Are they clammy? I'm doing a cap refill, looking to see if he's got less than 3 seconds for that the blood to come back into his fingertips, showing me that he does have good perfusion. Then I'm just going to look at, even as I'm going to go into a physical examination. I would already put on a SpO2 monitor. I would put on a 3 lead so I can already see a little bit of electrical activity that's going on in his heart to see if there's any abnormalities there. I would also take a blood pressure at some point to get that. So then I would just be going into an examination. I'd be looking at Pete and starting from the head, just looking at obviously the color in that, but also looking at just even if there's any jugular vein distension. I'd ask Pete to just turn his head to 45 degrees to the side and looking if that jugular vein is distended at all, which could show me that there's some cardiac malfunction, that there's some backup onto that right side. Also, I'd be just looking and seeing if the tracheal is in line, if it's medial. And the reason why is because if there was a pneumothorax, it could potentially push pressure and cause the trachea to be distended over to one side. Coming down to the chest, I'm looking to see if there's any deformities, any bruising, if there had been any trauma, if there had been a fall. I'm looking to see if it's equal rising and falling, even as he's taking breaths, which could indicate that there would maybe be some potentially pneumothorax, tension pneumothorax going on. I'm looking at just even as in how Pete's breathing, how he's indrawing, if he's having to use his intercostal muscles, and if there's just symmetry in that. Looking down at Pete's abdomen, I'm going to ask him if he has any abdomen pain, and if I'm just going to palpate, I'm going to go through the different quadrants and seeing as I'm palpating, is there any pain that's being deferred or right there. So I go into the different quadrants and palpate. Going into his legs, I'm going to look to see if there is any edema, which would show that there's some backflow because it's from congestive heart failure. So I'm looking for edema, swelling, if it's new, if maybe it's normal for him. If it's pitting, which it just shows to the degree of the edema that's going on. All right. So I'll also look at Pete's back, have him sit forward, and again there I'd be looking for any kind of deformity, and also if there's any sacral edema on the lower back, and that would be more from because he's been laying it down in bed, and again from cardiac malfunction. Okay, so then I'm going to go into auscultating Pete. I would auscultate here in the carotid. I wouldn't press on it, but I would just listen. I'm listening for any kind of bruits, which could indicate some stenosis. I would then when I listen to the valves. So I'm going to listen to his aortic valve, which is going to be just medial to the right medial above the nipple line. And again, I'm listening for bruits. I'm listening for if there's any mechanical abnormalities, which could show that maybe there's some stenosis or maybe that there's actually a problem with the valves. So I'd be listening to the aortic valve. I'm going to listen to the pulmonary valve, which is just left and above the nipple line, medial. Listening there. I'm going to be listening to the tricuspid valve again, which is just to the left of the medial, and also to the mitral valve, which is just below the nipple on the on the left side. So, we've listened there. I would at the same time, I want to listen to the lower lobes of his lungs, listening again for any fluid, which it could show back up onto that from the left side of his heart into his lungs and pulmonary edema. So I'm listening for crackles there. Once I've finished with that, I'm going to pretty much have come to the end of my assessment examination, and based on what I've found so far, I would tell Pete, listen, Pete, I realize you're not having any pain now. I believe you were having an onset of angina, and taking you on GTN has relieved that pain. However, you're still of a medium acuteness, which means that it is important that you do go to hospital, because things could change and could change rapidly. And we would load Pete up into, if he's happy to go to hospital, we'd load him up and we'd continue monitoring him en route to hospital. And I would go to hospital with Pete as a status 3 because he is pain-free. Thank you.